Alright, hello everyone. This is a little video to just review the process for musculoskeletal differential diagnosis. So as you're following along, there'll be three good documents to pull up. One is the differential diagnosis for soft and hard tissue, the double-sided PDF here that lists the main anatomical tissues and the history and the physical exam that goes with it. The second thing, this is going to be an elbow case, so it'll be helpful to follow along with the elbow sheet. And then the third one is the actual case here, which is what we'll spend most of the time on. So the plan is to look at this and break this out just a little bit. So at this point, I would say it'd be good just to pause the video, read through the history here, and then make some notes about what stands out to you. What is significant in this? What in here makes it more or less likely for one or another condition, considering the patient, her age, occupation, mechanism of injury, all those things. So go ahead, pause the video now and take some time. Take at least 5 minutes to write down some notes about where you think this case might be headed based on just the subjective history. All right, so let me show you some things that I would highlight in this case as having stand out to me as I read through this that may make it more or less likely to get one diagnosis over another. So let me highlight a few things here. All right, so let's just look at the highlights from the first paragraph here. So she is 55 years old and left-handed. So just with that, it tells us if she's over 50, that does increase the prevalence of certain conditions. We know cancer is one of those. We're not necessarily worried about cancer in this case. But over 50, we do know that arthritis and other bone conditions such as that do tend to be more prevalent. So I'm thinking that might be an issue. We also know that strength is decreased after 40 and so forth, unless it's combined with an exercise program. We know that's medial elbow pain, so that is a really important thing to point out. So the fact that it's medial is going to really focus in on a lot of different diagnoses. So it happened 2 months ago, so that factors into, once we figure out the tissue, the healing time frame. It's unclear about what exactly caused it, but we did note that P90X and kickboxing were highlighted. So if you think about that, P90X is going to involve a lot of different motions, but it isn't going to involve some type of weight or resistance, weight bearing or dumbbells, TheraBands, things like that. And we know kickboxing involves a fair amount of open and closed kinematic chain, depending on what she's doing with that. I think another thing to point out is that it is more painful afterwards as opposed to during the activity. So as we look at the sheets, that may focus in on certain things. Initially, she did have some swelling and warmth, so that indicates a chemical inflammatory response. And that was 2 months ago. However, she hasn't had anything since then. So now, at this point, it's safe to assume, reasonable, that it is a primarily mechanical problem at this point because she's not having swelling or warmth. Of course, we want to confirm that with our observation in our examination, but based on what she's telling us, it doesn't appear that a active chemical inflammatory process is likely. In terms of office duties, that factors into the position she might be in, might be compromised in certain positions with her posture or with the way her elbow or wrist is sitting on a table. And then we know that she does like golf. So thinking about golf, if she's left-handed, and if she golfs and swings left-handed, which is reasonable to think that she would, we know that it does place more stress on the medial aspect of the elbow, on the dominant arm, and the lateral aspect of the elbow on the non-dominant arm with the typical golf swing. So all that is what we're looking at from just the first paragraph. So let's clean this up and look at the second paragraph. All right, so looking at this second paragraph, again, we see the medial elbow pain. It gives us a little more detail into where that is inside of our forearm. And this is an important point. It is a prickly sensation. So, prickly may make you think pins and needles, paresthesia, so that may make you think some type of nerve involvement. So, this is an important clue here for this. It does not present any pain with the exercises initially, but now she has a low ache with push-ups and punches. So that indicates both of those are with some type of compression or close kinematic chain activity. So that may make you bias towards certain structures over others. Rest and ice are using her. She's using Aleve or naproxen for pain, and sometimes biofreeze over the elbow as well. That really doesn't tell us very much. So leave and biofreeze would not really help us gain much information in this case. Okay, then we have this third paragraph here. So let's see. So in the third paragraph, does anything stand out here? She does have a family history of hypertension, so we know that would be important to measure her blood pressure with that. Past medical history, seasonal allergies, good to know, but doesn't really change too much of our thought process. Now nursemaid's elbow, what is that indicating? We know that that's going to affect primarily the lateral aspect of the elbow, where the radial head articulates with the humerus, so more of a radial head dislocation. So it's interesting that that was a previous history. It may indicate that she has a general ligamentous laxity or an increased ligamentous, lack of ligamentous tightness or stiffness to her joint structure, but it doesn't really tell us too much. Now, this I think is something I would highlight and star. So, she was in a significant car accident not too long ago, about 6 months ago. And you may look at this and think, well, that was 6 months ago. Her pain started 2 months ago, so they may not be related. But they could be related. Still, not that long ago. Even though she didn't have any pain afterwards, besides soreness, there still could have been some type of underlying pathology, especially when we combine that with the prickly sensation. So combining those two things, so the prickly sensation along with the car accident, does it mean anything? I don't know, but it's something we're certainly have our interest peaked in at this point. Okay, so for the next step, listing your potential medical diagnoses. My suggestion for this one is to start back with this sheet. This would really apply to any joint in the body, but it's particularly good for peripheral joints, and looking at the various structures. So I'm going to walk you through this as I would apply it. So if I'm looking at muscle, we know that she's having medial elbow pain and into the lateral forearm. So which muscles would you think about with that? All right, there you go. So I typed in some muscles here. So you're thinking your flexors and protenter teres possibly. And if you look at this, whether that's muscle or tendon, we know that those structures are located on the medial elbow, and so those might be involved. So it'll be important to palpate those as a test to see if it's involved. So if you look at some of the history of repetitive eccentric activity, that could be true for kickboxing or P90X. Unexpected violent contraction, unaccustomed, not necessarily, but unaccustomed sudden activity or strain, that could be possible. Unaccustomed overuse, yeah, I think all those things could fit in with a muscle pathology. So with that, you could be thinking a muscle strain of any of these muscles. So that would probably be one of the first things you would add here. So you go back here and you would potentially add that. So you'd add these guys as a possible. So strain of FCR, FCU, FDS, protenter teres. So that's a definite possibility there. So then you'd go back to here. Oops, move that out of the way. And then you look at a tendon as well. So in addition to that, so in addition to this, you could have a tendonitis of FCR, FCU, FDS, etc. This obviously be a proximal tendonitis opposed to a distal tendonitis. But since we know that it's been 2 months and she hasn't had any swelling lately, so now we're thinking this is actually more of a tendinosis of those structures. So that is a possibility as as well. So those are some potential diagnoses. Let's go back to this list here. Okay, so you have bursa. There is a bursa on the medial elbow, aching at rest and pain with all motions. If the acute, so that doesn't really fit necessarily, but recent unaccustomed overuse or weight bearing, yeah, that fits in well. So initially, could you have had a bursitis? Yes. Let's look at capsulitis. Stiffness is not necessarily reported because we're chronic. Is there pain in one motion? Unguarded, swelling, trauma, so the acute things. But at this point, the patient's not complaining of stiffness. So I would go back here and I would say something like capsulitis as being unlikely. And I would not list that as a probable diagnosis. So that would be really limited, unlikely there. And so I'd go back to here and I'd continue to look down at this list. I know the screen's getting a little messy here. There's not a disc there. Now, what about nerve? She is getting some paresthesia, some numbness, some weakness, some potential weakness, but numbness, prickly sensation, cord-like pulling sensation. So yeah, I would say that nerves would be involved here. So now you have to think about, okay, which nerves are involved. Okay, so you have definitely the cubital. Let me go back to red here for probable. You have this cubital tunnel, which is ulnar nerve, obviously. What other nerves or innervations would potentially be around the medial elbow? So this is where you might think nerve root. And if you're thinking nerve root, you would typically be thinking about C8 or T1 nerve roots would be distributed in that area. So we would call this really a radiculopathy. Um, I would say this is a probable diagnosis because of the significant car accident. She had pain previously, but not any longer, and now she has a prickly sensation. I'm not going to say that nerve root is highly likely, but I think it's definitely a probable case there. And if you look at other nerve pathologies, does it seem like a carpal tunnel, median nerve? No, it doesn't seem like median nerve because she's not having a weakness in the hand or any complaints of gripping. We might notice thenar eminence atrophy, so that doesn't seem significant. What other nerves? How about radial nerve? No, radial nerve is going to be more weakness with triceps or wrist extension or posterior lateral if you're looking at a radial tunnel syndrome. So it doesn't seem like radial nerve. So ulnar nerve seems to be the most likely based on the location of the symptoms and or a nerve root pathology there. So we have four possible diagnoses there. And then we can keep going down this list here. What about bone? So what bones are there? Well, we're going to have definitely the humerus connecting with the ulna, and we know that push-ups and punching a bag would compress those structures, so that would be something to be considering. So with that, could there be some type of HU, humeral-ulnar bony arthritis that was inflamed by the recent activity? Could there be, or could there be some HU cartilage, articular cartilage injury? So those are possible as well. And then what's the other thing that on the medial elbow, we know that she also plays golf. So the other possible diagnoses, let me put that over here, right there, is we definitely could have some kind of MCL, or if you want to call it UCL, ulnar collateral ligament damage. That could be potential. It's a superficial structure. She does some swelling initially. Could she have done it with one of the plyometric activities? The P90X, could it have happened with the kickboxing? It's possible. I'm going to put this as a little more likely because if you think about MCL or UCL, there's typically a traumatic event that happens, and it would typically be common to have pain during the activity. So let me clean up this screen a little bit. So if you want to write any of these ones in red, those are our probable diagnoses down. So now I pulled up the elbow sheet. Let me just zoom in on this a little bit. So without even looking at the sheet, you can get most of these things already. And so with here, let me just highlight. Okay, there we go. So let's just highlight some of the things here. So we know medial elbow pain. Get my arrow here. Okay, so medial. Okay, so that's a possibility. There wasn't really any trauma, so it doesn't seem like a capsulitis would be likely. We know cubital tunnel syndrome, which we said before, medial. Pronotor teres, that's also medial. This is pronotor syndrome, which is more nerve related. Um, Medial nerve distribution. Why I think this is less likely. She doesn't seem to have this medial nerve distribution, so this is possible, but does involve golf and recreational, so that's another a possibility. And then supinator syndrome is not likely lateral, and this is lateral, so we're not thinking that one as well. So if you use this, it might give you some ideas. And at this point in the history, you're just trying to generate your hypotheses. You're not really committed to any one diagnosis or another. With your physical exam, that's when you start to really hone in on what you have hypothesized as it being. Okay, so let's go back to the sheet. And then let's focus on this area. What do we think are the most probable? And with this section, it's really about can you link something together. So for this section, I think some type of cubital tunnel syndrome would be probable. I think the rationale for that would be that she has paresthesias, or she describes as a prickling sensation, and location. Just like they say in real estate, location, location, location. With these differential diagnoses, location is really important. I think it's also very probable that she has some type of humeral ulnar joint issue, whether that would be an OA or cartilaginous issue slash irritation. And the justification for that is she has pain with closed kinematic chain activities, so I think that seems probable. Also, I still think a tendinosis is likely, so that's another good tendinosis of FCU, FCR, you know, flexor digitorum superficialis, pronotor teres maybe. That's another probable one as well, pronotor teres syndrome. I'm not as high on that one just because I think the distribution. So I'm going to say this is a weak one. Um, what are some things that I think would be unlikely given this diagnosis? Nothing here consistently seems. Let me pick a different color for this. Like a fracture, capsulitis, um, lateral epicondylitis. And I should mention here that when we said tendinosis here of that, or humeral ulnar joint irritation, that essentially could be a medial epicondylitis. But at this point, I would go back to here, and I would say another probable diagnosis that's really more of a generic term would be a medial epicondylalgia. So it's not specific, but that would definitely be an appropriate probable diagnosis as well, and I think it could be in a top two also because of the location of the symptoms, um, but it would not be, I just put here, not um, a epicondylitis. So not an epicondylitis. So with that, okay. Other things here, I would also put here. I also think I think it's a good reason to suspect a cervical spine radiculopathy. So that's another option as as well. Thinking about this going up to fracture, certainly we're saying there's no significant fracture because there's trauma. Could there be a stress fracture of the humerus or the ulna? Some of you may be thinking that it's a possibility. I'm going to say that's really, really far down the list. That's typically not a bone because it's a non-weight bearing bone. It typically doesn't have a stress fracture unless there's significant um, trauma or weight bearing. And I don't think with P90X or even the kickboxing once a week, that would be enough to initiate. So that's the rationale for why stress fracture would be unlikely. Now, if we're dealing with a lower extremity activity and lower extremity bones, because we're constantly bearing weight on our lower extremities, especially with running, walking, and those things, and with her age, that could be a possibility if there's a lower extremity, but not for upper extremity. It would be unlikely to get that. So there would definitely be some other potential medical diagnoses and other probable ones that could come up in a top two. But as I read the case, this is this is what I was thinking, and these are some of my conclusions. But other things could work depending on your justification and how you pieced it all together. So hopefully that was helpful to make some connections with this. Reach out with any questions, and good luck as you keep studying these cases and these materials. Thanks.